So without further ado, I want to say thank you all for being here. We have no disclosures. The written consent for all of our patients was obtained for the images and videos that we use in this presentation. And we're very close to our patients. So our background a little bit, many of you work with children with cerebral palsy and spastic diplegia and even spastic tetraplegia that benefit from selective dorsal rhizotomy. We know this is a well-validated, very effective procedure. There's various techniques that have been used to prove, that have been proven to be very efficacious. I think historically the multi-level laminectomy, and then Dr. Park in Washington University has talked more about less invasive approaches with the laminectomy at the conus. Well, I trained in Seattle under Samuel Browd, and I learned an Infra-Conus single level laminectomy technique. And I've made this my own, and I've taken it further where I don't even do much of a laminectomy. I do something called a Mini-Laminotomy, which is just a couple millimeters of bone removal coming in between two levels. And although the microsurgical work is a lot harder, we are finding that children are recovering a lot faster, have very minimal pain, and such little muscle dissection that their outcomes of getting into acute rehab immediately has been just remarkable. So these are a couple of papers that I'm very, that really inspired me. One is Dr. Farmer's paper from Montreal and the long-term outcome series of patients post-SDR. He was very adamant that of these patients, and he had 190 patients that he presented, you have to very carefully select the patients. I know all of you know this. In order to really get the best outcomes for a procedure like this, it has to be a very carefully selected patient with good core strength, and also with very key muscle groups that have excellent strength underlying the tone. In addition, there's been this resurgence in love and interest in the SDR technique, especially because the National Health Services of England had commissioned the SDR committee, and they've been assessing gross motor function before and after SDR. So this is a publication out of the Lancet, and they've really demonstrated that the post-operative quality of life in children is just remarkable. And I think from our data, we're seeing it's not only fantastic for children that are GMFCS level 2 and 3, but also in some of our more advanced cases of spasticity too, that the functional outcomes and also the satisfaction is far better than those in patients where we just place a baclofen and pump. So our objectives of our study were to look at what are the short-term effects on gross motor function and endurance. And understanding this, it was necessary to really prepare our families and therapy staff regarding what the expected progress should be in rehabilitation after surgery. And the reason I'm presenting the data that is really short-term, everybody wants to look at long-term, but the other piece of this is, well, we don't have the long-term data yet because we're a new program, but the main thing is most families are asking me very key questions. This is just one of our patients pre-op and fairly soon after post-op. But here's the key. Oh, I'm frozen 1 second. Okay. I wanted to answer the following questions from parents and caretakers of a child. I keep getting asked, what will be the functional loss for my child right after surgery? And this is pretty scary for parents. When will my child be able to walk again? And when will my child actually demonstrate improved function beyond what they're already able to do? And the way that we do our measures is going to be our gross motor function measures, a 6-minute walk test looking at endurance. We do gait analysis, and we also do video recordings at each segment of our time points in evaluating these patients. So we found these questions to be very important, and I thought, well, there's got to be a way for me to look at this statistically. So here are my research objectives. I wanted to delineate the pattern of change in motor function and endurance after SDR. We also wanted to identify if and when the children regain their preoperative motor function and their endurance, and then to further go forward to determine the rate of improvement, almost a predictive model per child in motor function endurance after SDR. So just briefly, I have to tell you, we're really proud of our surgical spasticity clinic. I really couldn't do this without my colleague, Dr. Erica Erlandson. We have been very fortunate that our hospital has provided us with a great deal of resources. At each of our clinics, we have our PM&R PA, the pediatric neurosurgeon, our PM&R physician, who is Dr. Erlandson. We have a pediatric orthopedic surgeon. We have PT assessment, OT assessment with speech assessment. We have an orthotic specialist. our social work, our nurse coordinator, and of course we have numerous residents and medical students who are excited to see these patients at each of their at each of their points. And what we like to think about this as is it's a one-stop shop. It's a 2 to 3 hour appointment. And if it's a initial appointment where we're considering SDR, the families are here for a long time, but they get their full analysis and full discussion. And in their follow-up appointments, if they're going to need a tendon lengthening or if they're going to need changes to their orthotics, they're getting it in this one-stop shop. So post SDR, we see our patients every 3 months, and we have a contract in place. Every patient has to sign the contract that they're going to be dedicated to doing this protocol. And we have a nurse navigator that helps families to provide the right services and give them the best outcomes possible. So our study methods, our patient population, this is data up until about 2000, little into 2019. So I still have to put my 2020 data in. But our inclusion criteria is good lower extremity anti-gravity strength. They need to be an ambulatory cerebral palsy patient. And as I mentioned to you, our technique, you can see this is really just about a centimeter opening within the dura. This opening is even a little bit bigger than what I've been doing now. I've gotten my incisions down below 3 centimeters. And we do pre-op and serial post-op GMFCS, GMFM 88, motor strength, range of motion, and 6-minute walk test. In this study, I've included about 24 patients, and they had at least 6 months follow-up. Now, most of our patients have about 2 years follow-up with the last year of data. And I have done all my own statistical analysis with the help of Dr. Erlandson, and we use SAS 9.4 for that analysis. So I had done a master's in clinical research and got really excited with all this data. So this has just been a great opportunity for me to put some of my skills to the test. And what I decided to use was a linear mixed model with a random intercept. And this is what was used to model the GMFM and the 6-minute walk test. And what it allows us to do is to estimate the period at which each of the patients regain their preoperative function levels over time, averaged across the individuals. In looking at how we were going to predict, I thought a linear spline model was going to be a really nice way to investigate the rate of change. So we know that there is a knob or a change right after surgery, and then there's the steady incline. And the idea of using the spline model is that there would be breaks. So at a point of 1 year or 2 years, I may need to change and take another look at what the rate of change is going to be, or the rate of improvement may be, or decline. And so this allows me to be able to put those knobs in and give to families, well, from this period to this period, this is the type of improvement you're going to see. So it also gives us a chance to be able to encourage and push families to really focus on the first 1 or 2 years, which is where we're starting to see is the highest incline in terms of improvement, and then some kind of a plateauing off. Although some of it, we have noticed that in our higher GMFCS patients, like level 4s, that they actually don't plateau and they get actually better, when they're a little older, somewhere between 2 and 3 years. So that'll be something else that we will hope to present in the future to everybody. So this is a spaghetti plot. This is profiling the 24 patients that were included in the study. And you can see that most of the patients have an immediate decline after surgery because they've learned to walk or ambulate, do a lot of their functions with their tone. So by taking away their tone and then retraining them, we see that by the time they're hitting 3 months and then subsequently into 15 months, they have these drastic improvements and then steady improvements. So this is over a course of 2 years. And then here I'm just showing you just the period of the first year. And you can see kind of stretched out how each of these patients responds. Now, we then took this linear mixed model and transformed it into the spline model, and I'll show you that next. This is the GMFM total score. This measure is for endurance, and this is, of course, the motor function measures. And you can see for the total score, we see a very similar pattern. The endurance is more affected by the procedure, but it also has a much more drastic improvement. And then we also focus on the GMFM total score in the first year. And then this is the GMFM-E. This is where we're kind of seeing patients where they're starting to really walk, run, jump. And we thought this score of all of the GMFM components, and subsets, this was one of the most important things we're looking at. Now, as we looked at all of the GMFM subsets, we also realized that some of these patients are demonstrating incredible improvements in just their daily activities and their ability to care for themselves, take care of themselves, and even in their speech and intonation. And we anticipate that, and I think there was a recent paper published about this already in one of the neurosurgical journals or one of the PM&R journals, because I think when we take away the tone that is really something that they focus on, they're able to focus on other activities of daily life and really improve from that standpoint. So that's going to be something else that we will be including in our comprehensive study that we hope to publish here soon. So this is a score in the first year, just kind of pushed out because we do see that the first year is where they have the most highest incline in terms of improvements. This was one of the first patients I had the privilege of taking care of. And this is pre-op, and she can barely walk here. And then here she's walking on her own with just the railings. She was about 4 years old when we did her surgery. And this is a family that's very happy with her care. She's now running. We can't even get her to come back to clinic because she just wants to run away from us. But I think these are also stories, as many of you know, and if you've taken care of these patients, there's a very emotional component to it. You really bond with these families and the patients. And, you know, I can't even get her to, follow my instructions anymore because this one's a very sassy young lady. And you can see she likes to swing on the bar. She doesn't even need the bars to walk. And I just can't get her to follow instructions anymore because that's how independent she's gotten about a year and a half after her SDR. So this is the linear mixed model statistics that I kind of analyzed a little further. And this is to look at where the rate of predicted improvement is. And what this is showing you based on what the statistics were is that we see that the 6-minute walk test, so looking at the patient pre-op to after surgery, it's somewhere between 9 and 12 months that they start to exceed their endurance that they had prior to surgery. So this is something we have to prep the families for. It's not an immediate thing right after surgery. There's a lot of work that goes into this, but the possibilities are just immense. And same thing with the GMFM total score and the subset of GMFM-E. What we actually see is that GMFM total score, we see that patients are starting to surpass it a little sooner than the endurance. It's somewhere between 3 and 6 months. And then GMFM-E, we're seeing that component of the walking, running, jumping, somewhere between 6 and 9 months. Every patient's a little different, but this is kind of what we can tell families. This is what you should expect. So the rate of predictive improvement in the number of feet that are ambulated during a 6-minute walk test from 1 month to 24 months. And I say 1 month because that's the piece of data I have after the pre-op procedure, is about 42.79 feet. So you can see here that with each month, they get better by about 40 to 45 feet in terms of their endurance. Then the rate of predicted improvement in GMFM total score from 1 month post-op to 24 months post-op is about 1.4 per month. And you can see, I include the pre-op to 1 month as a decline, but this is what we see as the dip. And we feel that that's important so that families know this is the expected decline immediately after surgery. And here's what you have to look forward to. And then similarly, the rate of predicted improvement in GMFM E-score from 1 month to 24 months is 2.4. So our potential pieces here that we've looked at are the 6-minute walk test, GMFM and GMFM-E. We have a bunch of other data. This was what we kind of started with, and these were our mean values for creating a predictive model with the Spline model, really to answer the questions of that would help prepare caretakers, our therapists, and even ourselves, so that we knew what the expectations should be for our future patients as well. So in conclusion, yes, there's a significant initial decline in functional measures immediately after SDR surgery, but we also see that there's a subsequent significant increase in functional measures towards, and in fact, for most patients, beyond the preoperative measurements. And patients tend to surpass their preoperative GMFM total score between 3 and 6 months postoperatively. And then in terms of endurance, this is something that's surpassed somewhere between 9 and 12 months postoperatively. And, all of our caretakers, therapists, with their time-based functional goals and expectations, this has become great information for us to be able to even use, in some ways, leverage for our insurance companies so that we can make arguments as to why we need to continue the therapy that we're doing. Because oftentimes we're battling with them to get the extra sessions with the patients that continue to benefit and help them with their improvements. Now, there's another piece to this, the style of gait, the improvements in pain and lower extremity function that are so much more subtle that cannot be captured with a functional measure score or an endurance, but those are also pieces that we look at through our video monitoring and gait analysis. So we've got a number of other steps to look at. We're looking to see like when orthopedic procedures are being done and is there any correlation with the timing of our SDR procedures. We're looking at the self-care activities, age association. We do see an association with GMFCS level, but I just don't have enough patients quite yet. We have about 34 patients now that have been included in the study. And I think as we start to get one or two more years of data, we'll be able to stratify by this. And with the longer follow-up, I'm anticipating they'll have to add another slope or another knot. And we'll have to see kind of what the leveling off of the functional improvement ends up being, or if there's even a decline later on. So this is a picture that was featured in a commercial for us on Thanksgiving Day special. We're very excited to feature one of our patients and the two of us in the operating room, but Dr. Erlinson spends time with me in the operating room as we do our neuromonitoring. And so at this point, I'd love to take some questions from you. We do know that there's some deficits in our research. We know about the subject heterogeneity and even cooperation between in children that are 3 to 7 years old can be quite challenging. And there's even within the subject themselves, biological variability. And we've got some measurement errors that happen because of just who's doing the 6-minute walk test or who's doing our GMFMs. But for the most part, these are pieces that we've kept very consistent in our clinic to minimize some of this.
Thank you, Nina. Thank you. That was really fantastic. Dr. Koo wanted to know the age range of the kids in the study.
Yes, 3 to 7 years old. I do have 2 patients that were 8 and I want to say 9.5.
Okay. And Dr. Huggins wanted to know, when you look at that drop in performance, is it consistent across initial functional level, or do you get more drop with kids who had lower functional level, that kind of thing? Are you aware of that at this point?
I could not determine that with this data, but with by adding 10 or 14 more patients with our new data, we're seeing that there are some patients that don't have quite extensive a drop. They still have a huge drop, but what happens is their incline. So the patients that have higher core strength and already underlying strength, or they don't have as many muscle groups that are involved in the tone, those patients, by the time they're reaching 1 or 2 months, their incline is more rapid.
Fantastic.